Hello, everyone, and welcome to today's webinar from the Association for Vascular Access.
Yeah, so welcome everyone. We're going to be talking today about standardizing and streamlining ultrasound-guided peripheral intravenous access insertion, and specific to aseptic non-touch technique. Little bit on disclosures. I am an owner and employee, as you've already heard from my bio, and I work with a variety of companies through PIC Excellence. I have also received or been involved with the receipt of grants and research support for a number of research activities. So today, our objectives are to evaluate the goals associated with ultrasound-guided PIV access. We're going to define antiseptic non-touch technique, talk a little bit more about the key points and key parts. Then we'll describe two different procedures using ultrasound-guided PIV placement with a sterile probe cover and with a protective barrier securement dressing, all incorporating the antiseptic non-touch technique. We'll introduce the AVA Transducer guidance document and some issues associated with patient protection, and then go on to discuss evidence for aseptic versus sterile ultrasound-guided PIV insertions. And finally, we'll summarize the aseptic versus sterile and transducer protection guidance requirements and some of the issues associated with it. So when we think about difficult intravenous access, we have to look at the number of patients that it's affecting. With our hospitalized patients at a census of over 500,000 every day, there are more than 60% of patients who require some form of technology or ultrasound-guided IV access. You know the patients, those that are grossly obese, those that are very elderly, and the list just goes on and on. So if we think about difficult intravenous access and how we apply it, some of the innovations that we can use in order to have the most successful results involve ultrasound. I think we can agree that the acuity in care has increased over the years, resulting in more and more patients that are difficult to access or have non-visible veins. You know the conditions, those patients that have diabetes, have chronic illnesses, they're dehydrated when they come through the emergency room, they may be IV drug users or have a history of cancer. So many different types of patients that have challenges. And what happens to these patients? Well, they get multiple accesses, many different attempts. They have placement in points of flexion, the antecubital fossa, the hand, the wrist. All of these areas may result in short dwell time and higher risk of things like phlebitis, thrombosis, and infection. Each patient that receives these multiple attempts, they have a much greater risk of complications overall, and these commonly result in higher rates of peripheral access failure. More and more attempts, the cycle keeps going. Ultrasound guidance in and of itself can help to facilitate greater success and reduce the number of attempts overall, which has a tremendous impact in a lot of different areas. Looking at ultrasound guided peripheral access, we have to consider what our goals are. As clinicians, our primary goal is to be successful, but ultrasound really should be used in conjunction with to aid us in gaining access to have a successful procedure, but we also have to think about the aseptic technique and how we protect our patients. Our goals are to perform a successful procedure, but also to apply evidence and patient safety practices, such as what we have with the AVA Transducer disinfection and guidance. We need to utilize a method of insertion that is safe, efficient, and cost-effective. And those three areas are most important and what we're going to focus on. So how do we achieve these goals? Well, okay, great. Ultrasound-guided insertion in the application of aseptic technique is what we're striving for. But if we look at our current state of practice, or what's the current state of affairs, there's a lot of inconsistencies. somewhat due to different departments that utilize ultrasound guidance, the emergency room, radiology, different departments within the intensive care areas and the nursing floors. And there's a lot of variable training that's gone on. With each and every procedure, there's frequent contamination during the procedure. We see a lot of inefficiencies in time, supplies, final site disinfection, and even the cost. The use of ultrasound for vascular access, and particularly peripheral access, presents some distinct challenges to existing recommendations because there's not a whole lot of evidence to guide us. Healthcare professionals that are responsible for vascular access also have a responsibility to ensure patient safety during these procedures. And according to the AVA Transducer guidance document, therefore they must address inconsistent practice with respect to cleaning and disinfection involving ultrasound-guided vascular access. So these are areas that we're working on and that we need to have some attention. All of you know I've been involved with vessel health and preservation in this process for many years. But if we think about ultrasound-guided peripheral access, it blends into vessel health and preservation and must be a component. By applying concepts of vessel health and preservation specific to trained and competent inserters, we can reach the highest level of success with best outcomes. We've seen this with some research, the PIV5 rights, which has resulted in outstanding dwell times with one catheter for each patient in more than 85% of the time. And so our goals are to make it successful, but also to protect the patient and to provide an efficient and cost-effective way to do this. And in order to do that, we do need more peripheral IVs to reach the end of treatment, have longer dwell time, and removal when clinically indicated or when idle and not being used. We need fewer interruptions in treatment and a reduction in complications. And with all of this, it makes it more cost effective. If we look at processes that improve efficiency and safety, standardization for ultrasound-guided PIV is really something we should consider. Goals for ultrasound PIV are not just about success. We also must strive to improve our practices as our commitment to our patients. If ultrasound-guided PIV insertions are inconsistent and with questionable aseptic technique, we really need to take measures to change that. And one of the ways to change that is through standardization. Standardizing the work sequence and the process and procedure for ultrasound-guided PIV can help us to reach our goals, help us to reach a higher level of quality and efficiency, help us to apply the evidence-based guidelines and research. It helps us to heighten productivity, increase safety, reduce waste. We can do standardization and actually make it work by applying some of the Lean Six Sigma concepts that are incorporated in the Plan, Do, Study, Act. So Judy, we now have our first polling question. Can you help us with that? Excellent. Thank you, Judy. Well, I think that we can see from these results that we have some room for improvement. Congratulations to the 39% who have already standardized your steps in your policy. I hope that you are doing regular measurement of the outcomes and of the procedures, doing observation to assure yourselves that there is competency and consistency with the practices. For the other 48+%, we've got some room to grow and improve. One way you can move toward standardization of practices is by using this Plan, Do, Study, Act approach. And what I've done here is tried to take this approach and apply it to ultrasound-guided PIV insertions in a way that you may be able to utilize within your facility and within your work process. It's a fairly straightforward process with the Plan, Do, Study, Act as outlined here, and we're going to go into a little bit more detail. When we look at the plan stage, the focus is on identifying the problems and gaps. We need to understand who, what, where, and when, so that we can apply those processes to standardize and integrate best practice. We're looking specifically about all those who are inserting using ultrasound for ultrasound guided PIV, looking at what education and standardization has already happened and where the improvements can be made in terms of aseptic technique. This is all specific to patient insertions at the bedside and the insertions themselves for the actual steps that are involved. The goals of the Plan, Do, Study, Act, and specifically for this plan, are to look at ways to protect patients, methods to reduce contamination and assure aseptic technique, and then specifically to find acceptable ways to provide patient protection with the transducer covers, either through some sort of sterile probe cover or protective barrier and securement dressing, which is a fairly new concept. In the do phase, we're looking to implement the policy and education, looking at using concepts of antiseptic non-touch technique, applying the AVA transducer guidance, and then performing data collection through intervention. And so the do phase is the application, the actual movement into the performance improvement and applying all that you have created in the plan stage. So specific to transducer and probe protection, as we think about best practices and guidance provided through our evidence, we need to look to management of the ultrasound device, and specifically that's the transducer or probe. Truly, the technical term is transducer, but for our purposes today, we're going to use the term interchangeably with probe, since that's kind of current practice with vascular access. And so specific to the transducer and probe protection, the guidance document that we now have with the Association for Vascular Access specifies that we disinfect the transducer before and after insertion. That's consistent with other guidance from the Infusion Nurses Society, from the AIUM, and other groups. We cover or separate the transducer probe from the skin, which the AVA document specifically says cover. So now we're ready for polling question number 2. Are you aware of the antiseptic non-touch technique and the approach for performing the procedure? Yes, no, or never heard of it?
So we have 71% that have heard of it, 13 no, and 16% have never heard of ANTT.
Excellent. Well, it sounds like the majority of you are aware of the ANTT, and so we'll continue to move forward and talk about what it really is. The antiseptic non-touch technique was developed by a nurse, Stephen Rowley, and Simon Clare from the United Kingdom. This practice is basically the standard of care within the National Health Trust in the UK, but it's also spreading across the world as an effective way to utilize aseptic practices within specific procedures that nurses do. And to get into a little bit more detail, when we look at ANTT, it applies to all aseptic procedures. But to define aseptic or asepsis, we have to look at and develop an understanding that what we're talking about is that the area is free from pathogenic microorganisms in insufficient numbers to cause infection. It just means that it doesn't eliminate all microorganisms, it just reduces the pathogenic ones and creates an environment that is going to have the best outcomes. The question that we have to pose is, can asepsis be maintained during an ultrasound-guided PIV insertion? And the answer is yes with ANTT, but the next question is, can sterility be maintained during an ultrasound-guided PIV insertion? And that's one that we're going to continue to look at. If we think of asepsis as the aim, Avoiding the term sterile for procedures is something that we have to consider because it's very difficult to achieve any procedure involving skin contact and maintaining sterility. We all know that it's impossible to completely sterilize skin, and so microorganisms are present everywhere. The goal is to reduce the transmission of those organisms or reduce the pathogenic organisms and make sure that it's a procedure that is as clean or aseptic as possible. If we look at the definition of sterile, sterile means free from all microorganisms, and that's just not possible with skin contact. ANTT is based on identification and protection of key parts and key sites at all times. That is to remember what's sterile and what's not sterile. To remember when you take the cap off of tubing that you shouldn't touch the end of the tubing. It's supposed to remain sterile. That's a key part. We want to make sure that we understand that each time you touch the skin and then touch the catheter or insertion site, that you may be transmitting microorganisms and causing breaks in the procedure. And so performing a procedure in a way that maximizes asepsis is really our goal for ultrasound-guided PIV insertion, and truly is a goal for all peripheral catheter insertions. ANTT approach is broken into two different parts, with surgical ANTT and standard ANTT. Surgical ANTT is a more sterile approach where critical aseptic fields are established with a sterilized drape. We would think of this more in terms of our maximum sterile barriers by creating a large field, by working with sterile gloves, by continuing to move forward in a process that provides a more sterile environment. Standard ANTT is one that's used more in nursing areas and bedside procedures where we protect key parts. The hands are clean. Usually gloves are clean gloves. Sometimes sterile gloves are worn. It depends on the procedure and the policy within the facility. And then you move forward with the process, keeping the key parts and key components separate. And understanding what you touch and what you don't touch. There's been a lot of confusion in the differences between sterile, aseptic, clean, and non-touch technique. The ANTT project is working to reduce this confusion by having clear guidelines for various procedures. And by using ANTT and aseptic technique during clinical procedures, it can prevent microbial contamination of the aseptic parts and sites by ensuring that they're just not touched. ANTT aims to protect these key parts and key sites from contamination from the healthcare worker. And if we're to define what a key part is, it's the part of the equipment that must remain sterile. Also could be considered an example of the syringe hub, mustn't come in contact with other key parts. And so we need to keep that area sterile. A key site is an area on the patient, such as an IV insertion site, that needs to be protected from microorganisms or contamination. So performing things like the basic precautions of hand hygiene, we can significantly reduce the risk of contamination of the key parts and key sites. And so applying whichever of these approaches, the standard or surgical, we're able to better meet this goal. And the clinical procedures that are managed with the standard ANTT are specifically less technical, more simple, shorter in duration, and involve relatively few and small key sites and key parts, such as with a peripheral IV insertion. Standard ANTT does require an aseptic field and non-sterile gloves, but if you have to touch key parts like the insertion site, sterile gloves should be worn. You've all heard that we need to disinfect the insertion site before we insert a needle, but ANTT focuses on if you need to retouch that site, if you need to palpate or find that vein again, which typically is not done with the ultrasound, then you would need to wear sterile gloves. And so that's the approach that's taken under standard ANTT. So the antiseptic non-touch technique, or ANTT, as you can see here with the focus on the key sites and key parts, as I've already described. But the key parts, the critical parts of medical devices, if contaminated, do provide a route for transmission of harmful microorganisms directly into the patient. So in IV therapy, these include any part of the equipment that needs to remain sterile, is within the fluid pathway. Key sites and key parts specifically are the insertion site, any sterile equipment or parts that must be remain covered or protected, non-touch to key sites or parts, as we've discussed, and if you must touch them, to use sterile gloves. It's also wise to develop an area where you can put all of your supplies and maintain that aseptic technique, as you'll see in the next slides. So by establishing a general aseptic field, either by putting out a drape or another area in order to maintain these key parts and key sites free from microorganisms, it allows you to work better. We see that with ultrasound guided PIV when we're using our kits, either an IV start kit or a kit that's designed for ultrasound guided PIV insertion that may have a drape or an overwrap that you can unfold and put your supplies on and maintain the aseptic approach. As you can see here, this is a poster that was created for the antiseptic non-touch technique that showed peripheral and central venous access. The green part shows you the setup of supplies where you clean the hands, clean the area that you're going to work with, and gather the equipment, being able to position it on a clean area. Hand hygiene is performed, non-sterile gloves are applied, and equipment is opened and prepared. And you can see within the middle section of the red, if the gloves remain uncontaminated, then you can continue forward. But if you've touched other areas, if you've contaminated your clean gloves in any way, they should be changed over. And then you continue with whatever procedure you're doing. Here it shows administration of gloves and the administration of medications, and then the completion of the process. But it basically shows you the process that you can go through for ANTT. And so now we're at a third polling question. Do all inserters at your facility use sterile probe covers, sterile gel, and maintain aseptic technique with all ultrasound guided PIV insertions?
So polling results, 28% yes, 61% no, and 10% are unsure.
So I would say that this is consistent with current practice, especially when we've been seeing practices in the emergency room and other different intensive care areas where ultrasound guided PIV insertions are performed, and the practices are variable, or asepsis is not always maintained. We see a lot of use of transparent dressings covering the transducer. There are some concerns about transducers and the effect of adhesives on the face of the transducer. And since this is the most expensive part of our ultrasound, we do need to be careful with it. And so thinking about sterile probe covers, sterile gel, and being able to maintain aseptic technique, this is part of our goal, what we're working towards in order to maintain asepsis and protection for our patients, and also in order to establish standardization with these procedures. So how does ANTT apply to ultrasound guided PIV? And I've tried to just kind of simplify it here and move through the process. Of course, hand hygiene, application of non-sterile gloves, transducer disinfection, and if you're going to perform assessment on intact skin, um, the the guidance is a little controversial about whether a cover needs to be used. I know that the Association for Vascular Access is continuing to look at that, but basically for intact skin, a disinfected transducer may be used at this time. Tourniquet is applied and the assessment is done to select the best vein and then mark the site, which allows you to focus on the area of the skin to disinfect well and to be able to go back to that site easily. Performing hand hygiene again, if your gloves are contaminated or if you're going to change over to sterile gloves. Disinfect the transducer again and begin to prepare your supplies and transducer for the insertion. Disinfect the skin and the selected area and the vein site, and consider that a key site after disinfection. So for ANTT, this will be a non-touch area. Assessment is performed and the site is marked. Disinfect, change gloves, use sterile gloves if that's part of your procedure, or maintain the antiseptic non-touch technique if using clean gloves. And then continuing, applying the gel to the skin or to the cover if you're using a protective barrier dressing. Visualize the vein with ultrasound. Make sure that you identify arteries or nerves in order to avoid them. And then perform the insertion. Thread the catheter, control the blood. During this period of time, you want a non-touch of the skin during insertion, protecting the area. Maintain aseptic technique by holding the hub, using gauze or other aids in order to prevent your touch contamination of the hub and insertion site. Clean the gel off the skin. Again, this is a very common time to contaminate, and so using ANTT, we want to make sure that we have aids to clean the skin from the residual gel in a way that maintains aseptic technique and prepares it for a dressing application. If using the protective dressing, you peel off a layer and it eliminates the gel, and then a securement device or a dressing is applied, making sure that the transducer is cleaned at the end and hand hygiene is performed. Simple 1, 2, 3 process. And so let's look at it a little bit more closely. When we think about accessing a vein with antiseptic non-touch technique, do you use ANTT? Do you use a sterile probe cover? Do you use a dressing that has a protective barrier? Basically, according to the AVA transducer guidance, a probe cover is necessary or some means to cover the probe and protect it from the insertion site. We would consider these acceptable within the research that has been performed, but there is limited evidence to show us and to guide this decision. Here's a very simple procedure that we have sped up in time, not necessarily to show you how to perform an insertion, but simply to show some of the key aspects of aseptic technique. Here, sterile gloves are being used in a sterile field setup, the sterile cover and gel, and then even a sterile field is established for the insertion process. The insertion is completed with verification of catheter within the vein, and then you maintain aseptic technique during the process, completing cleaning of the insertion site and application of the dressing. So our last polling question, question number 4, do you think gel and skin are on the skin are sources of contamination during ultrasound guided PIV insertions? Judy?
Questions up. So yes, 86% believe the gel and skin are sources. 9% no, and unsure of 5%.
So basically, we know that the skin is a source of microorganisms, even though we've disinfected the skin. And then gel in and of itself, depending upon what type of gel you're using, can also be a contaminant, as most of you have listed in your responses. If we think about asepsis and sterility, what part does gel play in this? Because I've been doing this procedure for a while and have had the opportunity to use a protective dressing, I now find that I don't want gel on my insertion site. It causes me to have residual gel and problems with dressing adherence. It has just been more efficient for me, but that's my personal opinion. I do believe that skin and the microorganisms present will mix with the gel and create a higher risk of contamination and of complications for the patient. I've done research recently on the ESCAPE study with skin and microorganisms, and we know that even the forearm has a moderate level of microorganisms that we need to be concerned about. We know that peripheral infections do occur, and so monitoring normal peripheral catheter insertion processes and standardizing, and then looking at ultrasound-guided insertion processes are important for us to protect the patient. And so we have to keep these things in mind as we're moving forward and look to the research and establish even more research to decide what kind of risk is there associated with gel. Is there a viable concern about the gel being inserted into the bloodstream? Those are concerns that I have had for many years. We do have some evidence. There's quite a bit that is involving probe contamination, issues with microorganisms and equipment. And so, of course, we do have guidance such as what you see here from the AIUM document on managing infection risk and dealing with our transducers. It talks specifically about cleaning the skin, about making sure that the transducer is disinfected between each procedure before and after, and then using sterile drapes and sterile probes. This is somewhat specific to central line insertion, but there's also a crossover with peripheral insertion, as we'll see in some of the upcoming slides. The AIUM provides some guidance documents for the use of ultrasound for vascular access as well as peripheral access, as does the Infusion Nurses Society. The Infusion Nurses Society in their 2016 standards of practice talks about using a large sterile transparent membrane dressing over the probe or a sterile sheath cover and sterile gel. I want you to stop and think about how many of your facilities are actually using multi-use bottles of gel for your assessment procedure and potentially even for the gel within the probe cover if you are covering with a sheath. Does that sterile cover ever get penetrated? Can that non-sterile gel leak out or cause problems? Do you effectively clean off the gel from the skin if you're using non-sterile gel? Almost all of the guidance documents that I have seen have recommended the use of single-use packet sterile gel. In addition to the sterile gel, there's more information that you can see within the AIUM information here that talks about using clean gloves, but maximum sterile barrier precautions are not required for peripheral venous access. A sterile ultrasound probe cover or transparent film dressing is what they recommend within the AIUM. And then there's another notation specific to midline catheters where they recommend that using full barrier precautions. Now, whether that full barrier precautions means maximum barriers, such as a large field, they do cross over and say placement should be similar to that for a PIC. But there is no evidence to tell us whether midlines require that same level that we have with central insertions. And so that jury is still out. There is some information and research that was done comparing infection rates to regular peripheral catheter insertions and ultrasound guided. And what they found was there was no statistical difference in the incidence of infection between the ultrasound and the traditional group. And you can see the numbers that were reflected here. They used non-sterile glove as a cover for the probe. So not a sterile sheath cover and not a sterile transparent dressing, but they used a non-sterile glove. They did use sterile gel packet and inserted gel into the glove and then on the skin as well. And even with this research, you can see the 5.2 per thousand catheter days and 7.8 per thousand. That was still a bit higher than I expected. And so if we think about, let me make sure I went in the right direction. Think about the packages that we're using. I know that I've been caught short before looking at some of our gel packets that I thought was sterile, and they actually weren't sterile. They were single-use packets, but not all of them are sterile. And so I challenge you to check your packages and make sure. The multi-use gel containers and bottles should not be used with our ultrasound-guided PIV access. And I have to say, with my observations at hospitals all over the country, I have seen so many different practices, even seeing tubes that were used on different types of intravenous catheters and Foley catheters with the SurgiLube and other types of products. And so I challenge you to make sure that there is consistency within the practice, that you're protecting your patients by making the single-use sterile packets of gel available and part of the requirement of performing any ultrasound-guided PIV insertion. So let's talk a little bit more about the guidance document within the Association for Vascular Access. This document is available at avainfo.org. I hope that you've all accessed it and intend to read it if you haven't already. The AVA Transducer guidance provides us with some excellent information, was well researched, and provides us with some information that we can apply to the procedures. Specifically, it states that during assessment, consider using a single condom or commercially manufactured transducer sheath, excluding transparent dressings or gloves during all use where there's the possibility of contact with blood, body fluids, or non-intact skin. Well, this is an area that I would like to discuss in a little more detail, but we are running a little bit short on time, and so I'm going to continue to move forward. Having some sort of a cover for assessment, I think, is still somewhat controversial since typically that's intact skin. But covering our transducer probe or separating it from the insertion site during the insertion procedure is all consistent within various guidance documents. And then specifically, this guidance says to perform all ultrasound-guided insertions with the use of a sterile sheath and single-use sterile gel, which we've already discussed. And so this needs to be part of the standardized practice. If we look at evidence-based practices, aseptic technique, our antimicrobial prepping, the transducer disinfection and management, and then the gel specific to single-use sterile gel packets, competency assessment is something that we also need to consider in terms of ultrasound-guided PIV access. Measuring competence specific to success levels, specific to adherence of aseptic procedures is part of a hospital's responsibility to patients, making sure that staff are performing in a way that is consistent with policies and consistent with the evidence that we have to guide our practice. Proficient inserters, as we've talked about, have fewer attempts and lower complication rates. And so ensuring that you have either a specialty team or education and competency assessment for all those physicians and nurses who are performing these procedures is very important to patient safety. Education is never a one-time event. We have to recognize that education needs to be ongoing both for making sure that staff understand the policies and procedures, and also that they understand the evidence that is backing up the need for certain components within the procedure. And so I would encourage everyone to be involved with education and make it part of our normal responsibility to provide some level of education to our fellow staff members, to contribute to education in a variety of ways so that we can all help each other and help the patient. If we look again at the AVA Transducer guidance document, intermediate level disinfection is appropriate for general processing of an ultrasound transducer. And basically what that means is we need to effectively clean the transducer with an approved cleaning agent. Look to the ultrasound manufacturer recommendations as well as to the definition of intermediate level disinfection and the products that fall under that. Further research is needed to address this critical topic and better understand current clinical practices related to disinfection competency. I know that AVA and the group that is involved with the transducer guidance document are continuing to review the evidence and to look at what is necessary as they look towards updating and providing the best information to help to guide our practice. Aseptic versus sterile for ultrasound-guided PIV. Specific to the evidence, we have no direct evidence about the impact of ultrasound in practice with PIV insertions. We do have some information on complications, but none in direct relationship to the contamination that may be associated or infection complications associated with a PIV with a sterile procedure versus an aseptic procedure. We have no definitive evidence that demonstrates a difference in infection rates with clean versus sterile gloves for specifically minor procedures. And what we do have research on is, laceration repair, dental procedures, and other types of minor procedures. And then there is indirect data in other practice areas that may favor reduced contamination by using sterile gloves. And so depending upon how your practice is in terms of the key parts and key sites with the antiseptic non-touch technique, you need to decide whether sterile gloves are necessary during your ultrasound-guided PIV insertions in order to protect patients. Part of our Plan, Do, Study Act, after you've done the application of your performance improvement, then study the results. Look at the information that you've collected. Do the results now reflect compliance with the guidance and policies? Have you reached a level of consistency with the aseptic technique and the insertions? Summarize the improvements and what you learned in order to move forward within this study section for the Plan, Do, Study Act. And then specific to ACT, this is an area where you look at your results, evaluate if there's still areas that are deficient, areas that require more attention. Was the intervention effective for making sure that there was compliance with the policy? And then act to see if any additional education or intervention is needed. The Plan, Do, Study, Act is a cycle. ACT begins the PDSA cycle again if there are still some areas that need to be improved. It's very difficult to apply an intervention and have 100% success. And so it's often necessary to go back through the cycle multiple times in order to achieve the level of success that you require for patient safety. And so look towards continuous improvement instead of a one-stop fits all type of intervention approach. Look to Plan, Do, Study, Act as something that we should incorporate into all of our practices in order to have that regular and consistent improvement. So in conclusion, we still have concerns over applications of aseptic technique with ultrasound-guided PIV insertions. The antiseptic non-touch technique has proven to be a safe and effective method to improve aseptic technique throughout the world for different types of minor procedures, such as peripheral catheter insertions. The use of a full sterile technique for ultrasound-guided peripheral access is controversial, and at this point in time does not have adequate evidence to support movement into this type of a practice or this type of level of cost. Safety in aseptic technique is improved through the antiseptic non-touch technique, and we're able to eliminate gel and transducer on the skin by using certain techniques that we've already discussed. If we look to the efforts of all clinicians, we need to work together to commit to performance improvement, to have competency assessment by all inserters, and to apply standardization of techniques that do lead to greater patient safety. There is still so much to do, and it takes all of us to do it. I also want to let you know that we're in the process of developing a research survey on ultrasound-guided PIV that you may be asked to provide your opinions on. You may receive a link in the future inviting you to the survey and to help to guide us in providing more information on how to make some of these decisions, as well as in order to provide kind of an economic evaluation. So thank you very much. It's been a pleasure talking with you.
Nancy, thank you so much. That was wonderful. I'll applaud for the group. So I appreciate everything. Now, we do have quite a few questions. Do you have time to stay on a little bit over?
Absolutely.
Beautiful. So one, we have a request, actually. This isn't a question, a request from our friend Adrienne from the UK. Brilliant session, but she's asking if participants that have a policy, standardized sets for ultrasound guided PIV, if they wouldn't mind sharing. So I'd like to be the conduit for that. And if any of you have a policy, standardized steps that you'd be willing to share, if you would send those to J Thompson, J, the letter J, and then my last name, THOMPSON, at avainfo.org, avainfo.org. And I'd be happy to find a nice spot to keep those so everyone can enjoy and hopefully take advantage of that. So we're going to go on from there. We've had multiple requests about sharing these slides. So Nancy, I already heard you're offered up for those, so I believe that's a yes. Is that correct?
Absolutely.
Okay. So
I believe in education. I believe that we should all share with each other, and that's just part of what we need to do.
So we are a vascular access team whose time is mostly spent in procedures. How does a team adapt an efficient way of following outcomes in relationship to ultrasound-guided PIV insertions? And what criteria do you think is most important to collect?
Honestly, I think that our electronic medical records help us with that if we're willing to work to establish those fields that we need in order to gain our reports. By having a field that specifies ultrasound used for peripheral access and providing education to the staff on the need for them to document discontinuation and complications that are associated with our peripheral catheters, we can then run reports that help us to get information back. But if we're talking about competency assessment and aseptic technique, you're right, that's really difficult, and we need to have infection prevention and others within the hospital to lend a hand to perform observation. You may even get some assistance from the specific department heads and others who are willing to fill out a form or a tool that you create in order to do the assessment. The first request was to have a procedure form, which I have loads of sample competencies and procedures. And by just having someone observe and fill out that competency form and note any areas of breakage, what you're really looking for is not to impugn the staff, but to identify gaps and needs for education so that you can address them with the performance improvement. And you just take little bites at a time. I recognize that everybody's busy, you're performing procedures over and over, but if one person and you can pass the staff back and forth, if people can take some initiative and identify areas that they want to improve in small bites, and then you work on it, and then you pass it to someone else and they work on something else that they feel like is important, then you can all make strides towards improvement. It doesn't have to be all or none. It can be small pieces of the pie moving forward. And then, as I said, the electronic medical records can also provide you measurements of success. And so if someone is doing multiple attempts with ultrasound guided insertion, they're having low levels of success, that's a great opportunity for education. I do encourage the teams to take the lead on going down to the emergency departments and providing education. Help them to know that you're the go-to person and the experts. They have to be able to do the procedures because time is important in the emergency departments, and so they have to learn. But they also need to know who to call if they're unsuccessful. And so work together collaboratively to provide these skills and to also monitor.
Thank you. So one of the concerns a team has, this clinician has, is the depth of the vessel and being able to assess for infiltrations because of the deep vessel. It takes a lot of fluid and before seeing the swelling.
So that's an interesting question. Let me see if I can approach it from a different way. If we're doing upper arm insertions, the veins are deeper. And using ultrasound guided PIVs, I would encourage everyone to be aware of the length of the catheter that is needed in order to provide at least half of the catheter within the vein. Otherwise, infiltrations are common. If you're using too short a catheter, then complications may be increased, especially in the upper arm. I would encourage the use of longer catheters or midlines in the upper arm, whereas in the forearm, uh, the veins are not quite at the same depth, usually not more than 1.5 centimeters in the forearm. Uh, we do have research that tells us that you have a greater success um, at 0.5 to 1.5 centimeters. And so by staying within these levels for novices, we may help to reduce the number of attempts and greater success. So just understand your depth. I created a chart that I share with everybody, and I think it's on my website at pickexcellence.com, where it provides you with the actual catheter length that's necessary for every depth. And the calculations were done in order to make it easy for you to simply look and pick the right length of catheter, because that is what I have found to be the biggest error and reason for infiltration with ultrasound guided PIVs, especially when you're at a depth of greater than 1.5 centimeters.
Thank you. Now we've had a couple questions about gel. Can you speak to what form of gel is used, single use or multi-use bottle?
Yeah, so I tried to cover that clearly, but let me go back through it again. If you're using multi-use bottles, the gel within those bottles is likely contaminated. And so you're using it from patient to patient to patient. With ultrasound guided PIV, that's definitely a source of contamination. Even if you're just using it for assessment, not a good idea. You're putting contaminants on that patient's skin that you may not effectively remove with your disinfection. Within the guidance of the AVA transducer disinfection, as well as the AIUM and other guidance documents, single-use sterile packets is recommended. They come in different forms, different companies, but everything is moving towards those single-use packets. And while there may be some controversy about clean gloves versus sterile gloves, or a full sterile technique with these procedures, there's really not a question about the gel that we need to use single-use packet sterile gel.
Absolutely. So back to ANTT just a tad, for ANTT, would you recommend using sterile gloves for PIV insertion with ultrasound guidance?
So I believe that nursing judgment needs to be applied in situations that it's important for us to think and to understand what it is we're doing. If you are following antiseptic non-touch technique and doing a good job of asepsis, which you can measure by having someone watch you, you can measure in a variety of ways. But if you're performing the technique without touching the skin for your insertion procedure, then you may not need sterile gloves. You may be performing efficiently and protecting the patient. However, if after you disinfect the skin before your peripheral catheter insertion, you feel the need to touch, or you can't help but touch after you've inserted the catheter, if you have any problems with touch contamination, then yes, you need to be using sterile gloves. But even with the use of sterile gloves, contamination is common. You are still touching the skin, you are still picking up microorganisms on your gloves, and so even with sterile procedures, we need to be following the antiseptic non-touch technique, despite the fact that you may have sterile gloves on.
Absolutely. Now here's one that I'll field for you. I'll let you take a sip of water. This question is, I've heard that actual sterilization, not disinfection of probes, is now being required between patients. Have you heard of that? Sterilization, no. Sterilization, the probes are not even, many of them in the IFU. You can't put them through sterilization. The heat will kill many of the crystals. First of all, you need to read the IFU for any probe you use. And whatever guidance you read, the IFU supersedes everything. There are many guidance documents recommended high-level disinfection. That's a step further than AVA has taken, and also AIUM and emergency physicians, I believe. But across the world, there are other high-level disinfection bedside modalities that are available. Right now, the FDA has not cleared those bedside modalities. SONS 1, there's one out there that is available. But the high-level disinfection, some of the probes are not even able to do that as well. So look at your IFU. Can it go through high-level disinfection? And if it can, do you have the workflow that would allow that to happen at the bedside and not impede ultrasound guidance? But again, your IFU really does play a bigger part in that than any guidance document you can read. Hope that helps.
Thank you, Judy.
You're welcome. Okay. I've seen Nick's chips on probe tips. Well, that rhymes, actually. That concerns me for disinfecting. Should these probes be replaced? I think we can both go a resounding yes together.
If there's damage to a probe, then yes, you need it checked out and need to contact the manufacturer that hopefully you still have a warranty on and can get a replacement probe.
Another question revolving that document is, it recommends not using a transparent dressing as a probe barrier. The rationale for that is it is documented that there are micro tears in those, and makes that not an appropriate barrier for the probes. So.
Well, and Judy, I'd like to say one more thing about the transparent dressing covers. While it seems like a good solution to just cover the probe and stick it over, it's difficult to apply those in a sterile manner. If you're using clean gloves, you're applying it and you may contaminate it as well. If you're using sterile gloves, you're going to contaminate your sterile gloves with the transducer. So there's not an easy way to do it. However, you can apply the ANTT approach. The other point is the adhesives that are in our transparent dressings, and even some of the newer sheath covers that have the adhesive that you stick the transducer face down on. It's my understanding from the ultrasound manufacturers that this can be a big problem and cause damage to the ultrasound probe in and of itself. And so I caution you about using adhesives on your transducers.
Absolutely, I've heard the same. So I want to thank everybody for being on the call. I know we've kept you a little bit over. We still have quite a few of you that stuck in with us, so I appreciate each and every one of you. Nancy, thank you so much. Eric. Again,
Thank you, Judy and Eric.
thank you. Bye, everybody.